please.
What I'm going to show you first is a patient which we treated some weeks ago. This is an 85-year-old male patient. You see the body mass index with 18 kilograms per square meter, had some previous heart failure hospitalizations in May this year, and dyspnea on exertion with a New York Heart Class 3. Looking at the echo, which you will see in a second, the cause of the dyspnea on exertion was a severe tricuspid regurgitation, measured as even torrential. As we just discussed, the patient had also permanent atrial fibrillation. He had suffered from a stroke in 2009, had some cardiorenal syndrome with a reduced GFR and some Crohn's disease. The TRI score was calculated to be 6 points, which correlates with a 22% predicted in-hospital mortality. Looking at the right heart cath and the medication data, you see that the mean PA pressure was 22 millimeters of mercury, the wedge pressure 11. This translates into an transpulmonary gradient of 11. And there was a significant V wave, as you see here, with 12 millimeters of mercury, no significant pulmonary hypertension. He's on 20 milligrams of toracamide and also an SGLT2 inhibitor. And the coronary angiograms showed no obstructive coronary artery disease, as shown in these three videos. This is the patient presentation in the echo. You see some good or slightly reduced left ventricular function, a mild MR, but you also can see on the right image in the four-chamber view that the right heart is severely enlarged, and the right atrium is also very, very big. When we're looking at right ventricular function, you see different measures. The TAPSE was 21 millimeter, the S-wave 11.5 in the strain analysis. We had some hepatic vein flow reversal, and you see also by the Doppler color flow the severe torrential tricuspid regurgitation. This is then the TE evaluation. You see a very complex valve with a very large gap. The gap measured between 10 and 8 millimeters at different aspects of the valve. But you can also appreciate in the transgastric view that we have one moderate-sized anterior leaflet, but then 3 or even 4 posterior scallops, and then also, and of course, the septal leaflet. And with this, I think I'm going to handing over to Becky.
You haven't shown CT, so I'm going to skip this. And just go on to the next. But this is just, these are all still frames because it's the smart screen. But the still frame that I took of the leaflets that I see, it is indeed a very complex valve. Initially, I thought there might be 2 posteriors, and there might be. But there also seemed to be a scalloped anterior. So extraordinarily complex. You can see that the conformation of the regurgitation is similar. So again, originally I thought there might be another commissure here. So it would be, I don't know if I can draw. So leaflet here, there might be another leaflet here, and then a scalloped and septal leaflet as well. So it's possible, although the color Doppler is suggesting maybe just a single posterior.
Becky, you mentioned already several difficulties in that valve, at least when it comes to here. First is increased number of leaflets. Mm-hmm. What other difficulties are there?
Yeah, so the increased number of leaflets, so we developed the nomenclature to describe the leaflets for communication, particularly during TEER procedures. But the complexity of the leaflets has been shown in a couple studies to reduce the ability to get down to moderate to tricuspid regurgitation with a TEER device. The other thing that we see is just the coaptation gaps. So the coaptation gaps and the complexity of the valves suggest that, again, these are gaps that are larger than 7, 8, even 9 millimeters. So we were getting up to 11 and 12 millimeters in some spots. And that, again, is another predictor of not being able to get to moderate. And remember, we just discussed that getting to moderate or less is going to impact outcomes, and this is mortality. So we're already thinking this is not such a great idea for the TEER device. And then when you look at the three-dimensional imaging, this is where we thought maybe posterior is indeed just a single. This is three-dimensional, by the way, off of a transthoracic. It's a near-field valve for the transthoracic echo, and therefore we're able to really reconstruct by 3 dimensions on transthoracic. And so this is, again, where we thought that there was a single posterior, a very scalloped, you can see the different scallops of the septal leaflet here. I don't want to draw on it because a small A2 and then a bigger A1, very complex valve. And then going along with that, and this again is transthoracic 3D echo, very high line density and spatial resolution because your echocardiographer, who I assume was Michael Nabauer, was able to get us a multi-beat acquisition. And again, you see the complexity of the valve with a very large central gap. And again, very difficult for us, and this is a 3D vena contracta area that I reconstructed of over 2 centimeters squared. So again, outcomes for torrential shown in the trials to actually not to predict that you will have fewer patients able to get to moderate. So multiple suspicions that we are not going to be able to use a TEER device effectively in this in the patient. And then the one other thing to think about is right ventricular function, right? So we know that, so if we're thinking maybe we need to be putting in a valve replacement device, these are devices that we, as you showed, take away all tricuspid regurgitation. And we've learned that the more tricuspid regurgitation you take away, the higher the effective afterload to that right ventricle. And you need the compensatory RV function in order to overcome that acute effective increase in afterload. We're getting RV strains of 29% or minus 29, which is very good. It's actually hyperdynamic for a right ventricle. And an RV ejection fraction, which I think Jorg will show in a moving image, of 53%. Very, very good. Should have enough reserve to overcome this increase in afterload. That's it.
So the chain of thought here are, why don't we do TEER? Because it's safe. Well, because the chances of bringing it down to moderate are not high enough because of the complexity of the valve and because of the gaps and also because there was color all over the place, which also doesn't make it very easy. That certainly biases the decision a little bit towards replacement, but then the question is, how good is right ventricular function? As beautifully demonstrated, the assessment of RV function was not just based on TAPSE, but you also had a 3-dimensional approach to it with a right ventricular ejection fraction and beautiful images. This is certainly the way forward. How often can you do 3D echo and get a reliable right ventricular ejection fraction in these patients?
Well, we don't know what is reliable, of course, at the end, but in an experienced echocardiographer, at least what I have seen in our lab is that very often, in the vast majority of patients, we get a good 3D assessment.
Becky, if you don't get a proper 3D assessment, do you think that it's required to do CT or MR to assess RV function before you replace the valve?
That's such a good question. Obviously, CT and MR are very effective in allowing us to see RV function and the global function of RV ejection fraction. The question is do we need it, and is it the one metric that predicts outcome and recoverability? And that we just don't know. So we've not been we require CT because we obviously, if we're going to size for annular devices or replacement devices, we need to have the CT. We don't necessarily require CMR to get us adequate volumes for ejection fraction yet. But I do think we're still learning about which metric of RV function will allow us to predict outcomes in all of these different TTVIs.
But I think for me, if I might jump in, as important as RV function is also the pulmonary vascular resistance. So if we are going to starting with a very low pulmonary vascular resistance in the beginning, the probability that this RV might fail, I think, is probably very, very low.
Yeah. All right, show us what you've done.
So I'm going to start this video, and I'm not going to talk with during the video because I think it's I hope at least that the sound is well enough. I want to show you here the EVOQUE valve system. This is the implant. You see that this is a valve which has 9 anchors for the fixation of the valve into the tricuspid annulus. You see the 3 bovine leaflets of the valve. The inner diameter of this valve is 28 millimeters. This valve has already been prepared in the transcatheter system. As you see it here, this is the 28 French delivery system. It has a very soft tip. The valve which we're going to use is already mounted in this capsule in this part here. Then you see that this delivery system has a long handle with several knobs. This allows us with the white and the blue knobs to expand the valve and to expose the valve. And the gray knobs, the light gray, the dark gray knobs are for the flexion of the catheter system, while the dark black one has the possibility to elongate the system so that we're getting deeper into the right ventricle or to come back if we need some more additional height. Now you see on fluoroscopy that we are already in the right atrium with the tip of our system. Now what we're going to do is that we're going to pull back this sheath a little bit, which allows us now to start with the flexion of the system. And you see that we're already moving slowly into the right ventricle. Very slowly and very controlled. I'm adding a little bit more flexion onto the system. And now we are in a position where it's already in the right ventricle, and we can now put the entire delivery system into the stabilizer, which you see here. This stabilizer allows us to then do all the movements in a very controlled and secure fashion. We're going to show you now by echo where we are located with the delivery system. You see the multiplanar reformation of the echo. You see that the lines are already superimposed onto the delivery system. What you can appreciate where the marker right now is that we are in the center of the tricuspid valve, which is also demonstrated in the upper left and upper right image. Furthermore, you can already appreciate the distal end of the delivery system, the marker band. Maybe you can point on that as well on the echo. The green one here, this is the distal end. And now when you compare this with the fluoroscopy, what we're going to generate is now a capsule gap. So we're going to start with the retraction of the gap. And by fluoroscopy, you see this, that the dark gray or black ring is moving to the left, closer to the valve. This generates this capsule gap here. And now we're going to see how deep this capsule gap is located within the right ventricle. We are now going to expose the anchors. For this, I'm using this white knob again, and I'm going to retract very slowly the capsule, which you can appreciate in the fluoroscopy. And now the anchors are starting to coming out, and they will flare to this 45 degree like this. And now we're going to see in more detail our position of the valve in the right ventricle. Now by echo, you can see the anchors in this 45-degree position. We added a little bit depth so that we're getting a little bit more deeper into the right ventricle, so that we're nicely below the leaflets but above the papillary muscles. At this point, we cannot retract the valve into the system anymore. So we're going to continue because we have a good position. And we're going to now expose the anchors to 90 degrees. It's again use of the white knob, and by fluoroscopy you can appreciate that the anchors are coming further out. And we're going to stop here at a position of 90 degrees. And this will allow us now to re-evaluate again our position in the right ventricle and also our position in relation to the tips of the leaflets. Now, as you can see by echo, with this 90-degree position of the anchors, we readjusted a little bit our system so that we're truly in the center of the valve. The leaflets are still above the system, above the anchors, and we will now continue with the exposure. Then we're going to flip the anchors so that they're facing backwards, like this. And now we can evaluate the echo and see if the leaflets are already nicely on the valve. Now, if you're going to focus on the echo, you're going to see the pointer in the green image on the right of the delivery system, where the leaflet is above the valve system. And you keep your eyes onto this position during the spin, which we're going to do now, that we are going to rotate this green box around the center of the valve. Becky, I think it's up to you now to demonstrate this again, correct?
Yeah, we'll show you a couple things that Jorg will finalize once he implants the valve. But what he's shown you and what is extraordinarily important for this particular device is to do this rotation. So he's using, and this is again Michael, I think, is using multiplanar reconstruction in order to image all 9 anchors. So you really have to image all 9. And so when you do the rotation, you'll be, you can go either way, clockwise or counterclockwise, but you're going to be rotating one of the planes. And Jorg says that they like to end up watching one side of one of the images, which is what we also do. And so it's going to be, starting over here, and then you're going to rotate around until you see all 9 anchors. And the important thing is that what you're looking for is for the tips of the, you want to identify all 9, but you want to confirm the coaxiality by having the tips of the leaflets roughly in the same position below the annulus, and the leaflets coming over the top of the anchor tips. So that means that you'll be in the correct position. And so then, so once you've ensured that that you've got the leaflets, then he's already shown you a couple of other things. One, that there's actually 3 different times in which we're looking for the leaflet rotation. One was when he was at 90 degrees. This is obviously a picture when he's already flipped the anchors. But at 90, and you probably did it and cut it out for the tape. But at 90 degrees, when anchors are out at 90, we will do a rotation to make sure that we're at the correct height. So we've learned from experience that if you're too low, you may get caught in cordy, or you may not be above the papillary muscle tips. And then if you're too high, once the anchors flip, they will flip up higher, and therefore you'll miss the annulus and the leaflets. And so we do it at not only here, but also, as Jorg has done, in addition, at the 90 degrees. So once it's already flipped, again, we're confirming coaxiality, leaflet capture, height to the annulus. And you can see that I've drawn the green and the red planes from the multiplanar reconstruction. And this is where we'll grab one of the planes and rotate. So this is green plane here, now green, I've just taken some screenshots. Green plane here, green plane here. He's going around systematically in order to see the leaflets coming over the top of the device. So leaflet over the top, here's the leaflet again over the top, leaflet again over the top, and this is the most important thing that we have. Now I'm going to try a different method here of getting to the next page. I don't know if this will work, but we'll try. Okay. Okay, so then the additional clues that we actually saw was that the level of the blue plane, which is your short axis plane, was placed just at the anchor, which would allow you to also see leaflets. And you'll see this on the live image. It also allows you to see the leaflets on the inside of all the anchors. So that's your double check. You have restriction of leaflet motion. You have the short axis view already in the blue plane. And by seeing the leaflets on the inside, you've double checked that you're in the right position. Okay, I think that's probably, yeah. So Jorg will show this in the end, so I don't want to give it away. But as he ends up expanding, you'll see there's also a double check again about location. Okay.
I think it's important to realize that we did this 360-degree spin at various levels during the procedure, and as you just mentioned, it has been cut out so that we keep the length of the video rather short.
I just erased it with my hand.
So I think I'm going to continue. Let's see if this is what we have seen. You keep your eyes onto this position during the spin, which we're going to do now. That we're going to rotate this green box around the center of the valve. And now you're going to start rotating, please. The spin, and now we're going to focus on each of those anchors. So this is an anchor in the anteroseptal commissure. We're going to rotate to the next anchor, which is in behind the shadow. Here again, the leaflet is above the anchor, and now we continue to the third anchor. Again, the leaflet is falling nicely from above onto the valve system, and we're going to continue until we are back to the home view, which is in the next 180 degrees. Now here we are in the posterior view. We're getting to the posteroseptal commissure. And now if we spin further, we see the septal image. And in all those images, the leaflets are well above the tricuspid valve. So this allows us now to further expand the valve, which I'm going to do right now. And you see this again with the white knob. I'm going to expose the valve a little bit further. The anchors are getting a little bit bigger. And now we're going to stop here and do another re-evaluation of our valve exposure. Now that we have confirmed our position again in another spin, we're going to now expand the valve further. And I do this again with the white knob, and you see by fluoroscopy how the valve is getting bigger and bigger. And we are going to go now fully back with the capsule behind this band here. And this is now the position where our white knob is out of function for the future. We're going to stay on this echo image and do another re-evaluation, because the next step will then focus on the valve expansion with the blue knob. Now that we have checked our position and did some minor adjustments, we're going to continue with the valve expansion. Now, as I said before, the white knob is already maxed out. We cannot use the outer capsule But now we're going to continue with the inner capsule, which is the blue knob. And as you can see now by fluoroscopy, I'm pulling back this inner capsule, which expands the valve a little bit further. Now you see how it is getting bigger, and we're going to stop here. Then in the next step, we do the final release. Now for this final release, I'm going to now retract the inner capsule further, and we're going to watch this by fluoroscopy. As you see now, this is expanding further, and now it's jumping free and stays stable as anticipated. I'm going to do a little angiogram. We have no conduction disturbances. This patient still has a heart rate of 100. Now finally also with the primary flex, and for this I'm going to take out the handle out of the delivery system. Now I'm going to remove here and now we're going to pull back the wire into the right atrium. Now it's in the right atrium, and now we need to bring back the capsule. First, the inner capsule again, as you see it advancing, and then now the capsule is completely closed again, and we can further retract now the system out of the right atrium. Now if we have a look by echo of our implant result.
Now this is the final result here. This is the EVOQUE valve with the leaflets here. This is the anteroseptal commissure. Here you can see the inflow in the valve. There's a tiny little regurgitation in the anteroseptal triangle. This is quite common. So this looks very good. If we look on the gradient through this valve, we have a gradient mean of 1 millimeter of mercury. This is also a very good result. And this is the 3D view of the valve in the final position. Down here is the aortic valve for 5 o'clock, just for your orientation. And this is the final color view with the inflow through the center of the EVOQUE valve.
And there's no regurgitation, which I think is really a beautiful result.
And that's it. Fantastic result. I have a couple of quick questions requiring short answers. You didn't pace. Why didn't you do that?
Well, pacing is not required. It's so very well controlled that there is no need for pacing.
9 anchors. Can you miss out on 1 or 2?
Yes, you can. Sometimes, if you have an anchor which is lying in the commissure, you miss, of course, the leaflets, but you should not miss more than 2 or 3 because that might be associated with some instability.
Lucas, can I ask you something about post-operative care? How long do you keep those patients on intensive care or monitoring?
Patients are basically on our ICU for 1 or 2 days, just to monitor heart rhythm. Then they go to the normal ward and are quickly discharged.
Okay. And then one last question: RV function, did it change? Did it go down? Did it get better?
The RV function dropped a little bit. So from this hyperdynamic state, it get to the more or less normal RV function. But we haven't seen the patient for follow-up yet. So he's coming probably very soon. And then we have a better understanding.
Good.
Thank you.